Today we will discuss the procedure of tonsillectomy. Tonsillectomy and adenoidectomy are one of the most commonly performed surgeries in the world. Not only in ENT, but if you see the total number of patients operated all over the world, tonsillectomy will top those procedures. So this operation is performed mainly in children, and in children adenoid enlargement and tonsil enlargement are very common, leading to high-grade fever, pain in throat, and repeated infections which obstruct the child to go for his school. The age of the patient should not be less than 4 years. ज़्यादा 4 साल से कम उम्र में आप नहीं करते, नंबर 1. And before surgery, one must take care of the bleeding profile. If the patient has history of infection, then you should postpone your surgery until and unless total leukocyte count of the patient comes to the normal. Okay, WBC count should be between 4 and 10. The platelet count should not be less than 150, and his PT, APTT and INR should be normal. So these are common things which you will keep in your mind, and you will keep the patient nil per orally. Okay?
Because surgical anesthesia stomach.
Because if you give anesthesia, then the patient can vomit, and due to that vomiting, in anesthesia the patient can aspirate the vomiters, leading to very serious complications like aspiration pneumonia. So in every surgery, the stomach should be emptied, not only in tonsil and adenoid, but in all surgeries, the the stomach must be emptied. At least according to the anesthetist, they keep the patient NPO for 6 hours. So 6 hours NPO is mandatory for tonsillectomy and adenoidectomy. So these are some preoperative measures. Those you will keep in your mind, and on the operation day, the patient is tagged and is shifted to the operation theatre. And if you are performing adenoidectomy and tonsillectomy both, then which direction you will give to the anesthetist? You will ask the anesthetist to pass endotracheal tube per orally. If the endotracheal tube will be passed per nasally, then you cannot perform adenoidectomy because your tube will come in the way of your surgical field, that is in the nasopharynx. So if you are going to perform adenoidectomy and tonsillectomy, the endotracheal tube will be passed per orally. Okay, so if you are going to perform adenoidectomy, you will have to pass endotracheal tube per orally. But if you are going to perform only tonsillectomy, then the tube can be passed, and it is good to pass the endotracheal tube per nasally. Okay, because per nasally, when you pass the tube will remain in the center more. Okay, and when you pass the tube per orally, the tube can go to the left or right side repeatedly, and until unless you keep your pharyngeal pack in such a way that it makes the tube in the midline. That means when you will pack the hypopharynx with a piece of gauze, that gauze piece would be equal on left side and on the right side of the endotracheal tube. Okay?
Now
adenoidectomy हो गई है.
Tonsillectomy की तरफ जा रहे हैं.
Okay. First you will perform adenoidectomy. Okay? And the tube, in the same setting, you will perform adenoidectomy and tonsillectomy both. So which operation you will perform first? Adenoidectomy, because adenoid are present in the nasopharynx and it can bleed. So until unless you remove tonsils, the bleeding of the adenoid would be stopped, because mostly it is a blind procedure, and after performing adenoidectomy, you pack the nasopharynx with a gauze. Okay, so you pack the nasopharynx and then you perform tonsillectomy. Your question was the tube will obstruct the hand of the surgeon or the field of surgery by the endotracheal tube. No. What happens when you apply Boyles-Davis mouth gag? There is a hole in the tongue plate that will press the endotracheal tube with that tongue plate, and it will not press the lumen because there is a space between the
The
tongue plate of the Boyles-Davis mouth gag, and that will not press your endotracheal tube, number one.
Right.
That is, I think, the answer of your
Yes.
question.
Yes.
Okay. The answer is when you place the tube in the midline, the tongue plate of Boyles-Davis mouth gag has a space, has a cut in between the tongue plate, and that cut will come over the tube and it will not compress the oxygen supply or any gas supply to the patient during surgery. Okay. So when you arrive at surgery, you will first of all hand the patient over to the anesthetist. Anesthetist will give him anesthesia, that is general anesthesia. These surgeries, adenotonsillectomy, are always performed under general anesthesia. Okay, so when the anesthetist make the patient anesthetized, then you will start your work. First of all, position of the patient. How you will make the position of the patient? Patient should be in supine position, and you will place a sandbag under the shoulders of the patient, and no head ring during tonsillectomy and adenoidectomy. No head ring. Head ring is placed under the head of the patient only in nose surgeries. In tonsil surgeries and adenoid surgeries, the head ring is not placed. Understood? Why it is not placed? Because the head of the patient would be stabilized by the bipods and the plate. Okay, so the bipods are fixed to the mouth gag of the patient, and the mouth gag and head of the patient would be stabilized with the help of bipod, and that bipod will be inserted and will be fixed in the holes of the wooden plate or the metallic plate that is placed under the neck of the patient. Okay, so this how you make the position of the patient. That position is known as rose position, and where the surgeon will be seated during surgery.
Right side.
No. Surgeon will be seated or surgeon would be standing?
Standing.
No. During tonsillectomy, the surgeon would be seated. Patient would be lying supine on the operating table. Suppose this is operating table and I am the surgeon. I will be sitting behind the patient. First of all, I will make the position of the patient. How I will make the position of the patient? Supine position with extended head, okay, and sandbag under the shoulders, and then
Fixed with
no head ring. Very good. And this position is known as rose position. Then what I will do? I will take Boyles-Davis mouth gag that we have described earlier, and that mouth gag has a tongue plate. Then the size of the tongue plate would be selected according to the mouth of the patient. There are different sizes of tongue plates. Then you will take appropriate size of tongue plate. Then you will press the tongue of the patient with the help of tongue plate. Patient would be lying like this. You will open his mouth and then you will perform suctioning of the oral cavity. Then you will apply tongue plate along with Boyles-Davis mouth gag that we have already discussed under the heading of instruments of tonsillectomy, and you can watch that video if you are not aware of those instruments. Okay, so we will apply Boyles-Davis mouth gag with tongue plate, and we will keep the tube, the endotracheal tube, in the middle of the tongue plate so that it is not compressed. Then after pressing the tongue and after opening the Boyles-Davis mouth gag, first of all what you will do, you will perform suctioning of the oropharynx. You will suction the oropharynx and then you will make the oral cavity and oropharynx free of secretions. Then what you will do, you will take a piece of gauze with the help of forceps and then you will insert that gauze or pack. You will pack both sides of hypopharynx lying on the endotracheal tube. The endotracheal tube would be passing in the center, would be passing through the center of the posterior pharyngeal wall. Then you will insert your gauze piece, your piece of gauze on one side and then on the other side. Why you will pack the hypopharynx?
To prevent, to stabilize and to prevent any movement of endotracheal tube.
Number one,
Fixation,
that you
fixation.
can also say, but that is normally fixed. And after putting that endotracheal tube, we also inflate the balloon. The main purpose of packing the hypopharynx
Prevent aspiration.
is to obstruct the entrance of the blood and secretions into the airway. And what is the other method of preventing these products, that is saliva and blood,
Suction.
into the airway? Suctioning, and you inflate the balloon of endotracheal tube so that these liquids, the secretion and the blood would not enter into the airway. Okay, so you will perform suctioning and then you will insert piece of gauze on both sides of endotracheal tube. Okay, done. Then what you will do? You will start excising the
Adenoids and
adenoids and tonsil. Which structure you will remove first? Adenoid. I told you earlier why you will remove it. You will remove it with the help of adenoid curate with guard. Okay, adenoid curate with guard is an instrument which is used to remove the adenoid. Okay, during adenoidectomy, what you will do? The patient would be lying like this. You will not apply bipods to stabilize the neck of the patient while you will perform what? Adenoidectomy. You will keep the head of the patient under your left hand if you are right-handed person, and then you will hold the adenoid curate in your right hand like a dagger. Okay, then you will insert that dagger like you will insert that adenoid curate inside the nasopharynx of the patient, and then you will perform squeezing movement of the in the nasopharynx to curate the adenoid.
curettage.
To perform the curettage, you will curate the adenoid in the center and then from the sides of the nasopharynx, so that you will remove whole of the adenoid tissue. Okay, understood? And prior to perform adenoidectomy, you will always palpate the adenoid with the help of your index finger. Whether or not adenoid are present in the nasopharynx, this you will have to confirm first, because in some cases there may not be adenoid, there can be mistaken report, the radiological test, the x-ray. So in such cases, the digital palpation is the most reliable method to diagnose the adenoid. So after performing adenoidectomy, one must take care that he should not apply more force during the curettage, so that joint of the vertebra cannot be dislocated. That is a very serious complication, and the surgeon should keep this complication in mind. While you will perform the curettage, you should not apply more force. Understood? That is mandatory, because that can cause dislocation of the vertebral joint. Understood? After performing that adenoidectomy, you will insert a pack in the nasopharynx like this, in this manner. This is the patient lying, and what you will do, you will take a pack and then you will insert the pack inside the nasopharynx tightly, and then you will move to perform tonsillectomy. How you will perform tonsillectomy? Suppose you are performing right-sided tonsillectomy. Okay, so after performing adenoidectomy, you will move towards tonsillectomy. Suppose if you are performing tonsillectomy, patient is lying like this, and then the mouth of the patient is opened, Boyles-Davis mouth gag is inserted, and the throat is packed. You will take tonsil holding forceps if you are performing right-sided tonsillectomy, then tonsil holding forceps would be in your left hand. Okay, and you will hold the right tonsil with your left hand, and then you will move the tonsil in a very gentle way to see the attachment of the tonsil with the pharyngeal wall. Then with the mucosa, you will have to separate the tonsil away from the tonsillar bed. Okay, so you will appreciate the fold where the tonsil is attached, and then you will take a blade, surgical blade or tip of diathermy in your right hand, and then you will make very superficial incision with the help of a blade. Normally number 12 size blade is used. You can also use 11 number blade as well, but you should not use big blades because you will have to incise only the mucosa. After making an incision in the mucosa, you will take tonsil dissecting forceps in your right hand, and then you will retract the mucosa. Then you will take straight artery forceps in your right hand. Then you will insert the tip of the straight artery forceps in the incision, and then you will open the straight artery forceps. So the tonsil tissue would be separated from the bed, and then you will take a very little gauze piece and you will insert that gauze piece inside the incision. The best dissection is the gauze dissection. Okay, so you will insert that gauze in the tonsil between the tonsillar tissue and the bed, and then you will take tonsil dissecting forceps in your right hand if you are performing right-sided tonsillectomy, and then you will start dissecting tonsil away from its bed with a very gentle movement. So the tonsil would be dissecting towards the pedicle, the lower pole, you will reach up to the lower pole. Then you will take negus artery forceps in your right hand, and then negus artery forceps is basically a curved forceps. Then you will pass it through the pedicle where the tonsil is attached, the lower pole, and you will clamp the lower pole with the help of negus artery forceps, and the pedicle is ligated in the negus artery forceps. Now what you will do, you will take 1 number sized silk thread, one size 10 silk, and you will make a loop. You will pass that loop through the negus artery forceps. उसमें आप ऐसा loop बना लेंगे knot करके. You will knot the thread, and then you will pass the loop of the knotted thread through the negus artery forceps. ये negus artery forceps है, उससे आपने डाला, forceps से पकड़ा, then you will pass the loop through the negus artery forceps, and then you will put the loop behind the negus artery forceps, and now both ends of the size 10 thread are outside the oral cavity. So what you will do, now you will try to knot the thread with the help of knot pusher or ligature carrier. You will put the ligature carrier over the knot, and then you will take the knot towards the pedicle, and then with the help of fingers you will tie the thread in your ring finger, and with the help of your thumb and other finger you will tie the knot. You can also take help from the straight artery forceps in your left hand, and with the right hand your knot pusher would be pushing the knot, and then finally you will tie the knot. Then you will take scissors, the tonsillar scissors in your right hand, and with the help of your left hand what you would be doing, you would constantly holding the tonsil. So with your right hand you will cut the tonsil. Now the tonsil has been excised. After tying the knot, you will take the scissors in your right hand, and then you will cut the knot, and then you will release your negus artery forceps, and finally you will remove that pack earlier you inserted in the tonsillar fossa to check the bleeding. You will take help from very small cotton wools or gauze rolls to check the bleeding in the tonsillar fossa. You will secure the bleeding with the help of ligatures and diathermy, and you will also give some time. You will pack one tonsil and then you will move towards other tonsil, and you will repeat the procedure, and the hands will be changed respectively. The hand which were using in your right tonsillectomy will be changed. Like if you are performing left-sided tonsillectomy, then with the help of right hand you will yes, excise the tonsil. Okay, so after performing tonsillectomy, you will move again towards the pack that you inserted in the nasopharynx after adenoidectomy, and then you will remove that pack and you will check for bleeding. Okay, you will secure the bleeding of the tonsillar fossa as well as you will secure the bleeding from the nasopharynx, and then you will not de-scrub. You will ask or you will hand the patient over to the anesthetist. Then anesthetist will finally check the bleeders and he will give you green signal to de-scrub. Until unless you will not de-scrub, you will have to remain there during whole of your procedure. Understood? Any question?
When we excised the tonsil, we when आपने बहुत ज़्यादा मुश्किल से knot बांधी, why not just cauterize it?
Yes, there is other way of performing tonsillectomy, that is tonsillectomy with the help of
Cauterization.
diathermy. But that method, I think it causes more pain. Lot of surgeons perform this method, but in I usually prefer the dissection method.
नहीं specifically वो जब knot end में
नहीं, उसमें देखो ना, उसमें होता ये है कि ideally that pedicle should always be tied because there can be some vessels in that pedicle, and if you cauterize it, later on infection can occur leading to very severe bleeding. So chances of bleeding are more in cauterization of the tissue than the ligature. What should be the position of the patient after surgery? After surgery, the patient should be kept in left lateral position with head is elevated, with raised head end. Okay, because of the fear of aspiration. Patient can aspirate the blood into his airway. So to avoid that, the position of the patient should be kept on left lateral position, and the attendant should ask to apply ice packs over the neck of the patient. This ice packing of the neck will cause vasoconstriction of the vessels, leading to less chances of bleeding. Okay, so these are some post-operative cares you will take after surgery, and you will give IV antibiotics as well. But the role of IV antibiotics, that is post-operative IV antibiotics, is controversial. Some surgeons do not prescribe IV antibiotics after surgery. Okay? Sepsis is also one of the complications, but normally I have seen very few cases of infection after head and neck and after ENT surgery, because this field is not prone to infection that much. Like orthopedic surgery, there are a lot of infections after surgery. But in ENT, I've very rarely seen infections post-operatively. The major complication of tonsillectomy and adenoidectomy is bleeding. And the bleeding can be very horrible, you know. There can be reactionary hemorrhage, that is hemorrhage occurring within 24 hours of surgery. Okay, that bleeding can occur in the recovery room, in the operation theatre table, just after surgery. It can happen in the recovery room. Then what measure you will take? If there is immediate bleeding after surgery, what you will do?
Instantly admit कराएं.
You will take the patient in the operating theatre again, and you will ask the anesthetist to re-anesthetize the patient, and then you will open the field and you will identify the bleeder, and then you will catch the bleeder and ligate it, or whatever you will do, diathermize it. So this is reactionary hemorrhage. The hemorrhage can be primary, the hemorrhage can be tertiary and secondary as well. So these hemorrhages, and what is the cause of hemorrhage if the bleeding is occurring, suppose 5 days after surgery? What you will do if a patient is suffering from bleeding after tonsillectomy, that is 5 days after tonsillectomy, what could be the possible cause of that bleeding?
Positioning of the patient?
No.
The anastomosis, the fish.
What could be the cause of bleeding? What could be the cause of that bleeding, the bleeding that is occurring 5 days after surgery? Infection. Infection. In such cases, you will not open the surgical field. You will not take the patient to operation theatre to locate the bleeder. What you will do? You will change the antibiotic. You will start intravenous antibiotics. You will see what is the cause of his infection. You will have to combat the infection. Okay? So only you will take the patient in the operation theatre when the bleeding is occurring in the recovery room or in the operation theatre. In cases where infection is the cause, you will give antibiotic. Understood?
The other complication?
Mostly you can damage the neighboring structures. The complication can be per-operative. Okay, complication can be due to anesthesia, complication due to surgery, complication due to incision making, the site of the incision. You can make your incision at not at a proper site, so you can develop complications due to wrong incision. The complication can be due to bad dissection. Due to dissection, there can be chance of more bleeding. You can perform deep dissection. You can injure the neighboring structures as well. So these are the complications due to dissection. Complications due to positioning of the patient. Complications due to positioning में वही जो मैंने आपको बताया था ना, there can be aspiration. Then there can be joint can be dislocated. Okay. Complications due to anesthesia. Anesthesia complications due to anesthesia medicines, due to wrong handling of the patient, due to complications due to dosage of the medicines, complications due to endotracheal intubation के दौरान you can cause so many complications. So these are the complications of anesthesia. General complications I told you, like complications due to
surgery,
due to positioning, complication due to incision, complications due to dissection, okay, and there can be injury to the neighboring structures. If you if you open the mouth gag with great force, you can dislocate even this mandibular joint. You can cause injury to the angle of the mouth. And when the patient will wake up, he will ask you that, doctor, I am having some injury at this region. If you use more diathermy, then you can burn the neighboring structures as well. So these all are the complications of tonsillectomy.